Chapter 17, Somatic Symptom Disorders. So the clinical picture of somatic disorders, this is distressing symptoms or associated health concerns without significant findings, okay? So if you ever heard somebody say, well, they're somatic, that means that they have these symptoms, but there isn't any physical cause for them. So there's something going on in their mind, in their brain, typically, that's causing these symptoms. That doesn't mean that they're crazy. It could be in response to stress, for instance. People lose their hair, they have increased heart rate, they have high blood pressure, they have all kinds of things during times of stress, but there isn't anything actually wrong with their heart. There isn't anything wrong hormonally that's making them lose their hair. So it's not because somebody's got something off in the brain that they have somatic symptoms. It's symptoms that happen physically without any physical findings for or any physical cause for them. So there's a predominance in women for this. Somatic symptoms account for 40% of physician visits, with only 26% identifying a biological cause. The highest cause of misdiagnosis is the PCP's dissatisfaction with the clinical encounter. So basically, what that is saying is that the doc is tired of it. They're not interested in it. They like, there's nothing wrong with you. Please stop coming in here with this. They're dissatisfied with the clinical encounter with the patient because there's, you know, they can't figure out what to do for them because they have these somatic symptoms. So illness, anxiety disorder. So we're going to talk about a couple of disorders under the somatic chapter. This was previously known as hypochondriasis. This is a preoccupation with disease or illness. So if you ever have called somebody or heard somebody be called or have been called yourself a hypochondriac, okay, that's exactly what where this came from, is that somebody who's got this preoccupation with disease or illness, like this is wrong with me, this is wrong with me, this is wrong with me. This can be quite obsessive and intrusive to the patient's thought process because it's real for them. It's chronic and relapsing. It's amplified during stress. So the patient that goes through stress will feel like they have much more wrong with them during that time. I actually always kind of joke that I had probably a little of this going on during nursing school because everything I learned about, I thought, oh, that could be me. I could do that too. I think I might be able to have all of those things. So the next one we're going to talk about is conversion disorder. This is neurological symptoms in the absence of neurological diagnosis. So this is attributed to a channeling of emotional conflicts or stressors in physical symptoms. Many patients show a lack of concern about the symptoms. In childhood, physical or sexual abuse is common for patients that have conversion disorder. So, you know, think of all the neurological symptoms that we've talked about in the past, and, you know, like, I don't know, different like pins and needles, for instance, or dizziness, or, you know, seeing spots. I mean, anything you can think about with the brain that could cause neurological symptoms, but there isn't an actual neurological diagnosis. So again, that's emotional or stressors that are being turned into physical symptoms, but it's actually some kind of an emotional conflict going on with the patient. So psychological factors affecting medical condition, they present risk factors for medical diseases. So there's links between mental disorders and physical diseases. Depression, we have a much higher risk for cardiovascular disease and cancer, a patient that has depression. Stress, a physiological factor that can affect a disease process. Stress is that's what that should say. I'm not sure why I did that. But anyway, so stress is a psychological factor that can affect a disease process. Obviously, I think many of you already would have that understanding and know. Think about during times when you've been stressed out, or even right now, like, you know, your body's a little more run down. We don't take care of ourselves as well when we're under stress or we have depression. So these are things that can affect our medical condition. It starts out psychological, and then it can affect our entire body. Cultural considerations, your book talks about a little bit, so I just wanted to throw these in here since just last week we talked about cultural implications. So sensation of worms in the head or ants under the skin is more common in Africa or Southern Asia. Somatization disorder is rarely seen in men from the U.S., but often reported in Greek and Puerto Rican men. And PTSD and depression are more prevalent psychiatric symptoms in North Korean defectors to South Korea. So if you don't know what that is, those are people who have gotten out of North Korea and they end up being protected in South Korea, and so they find that there's much more PTSD and depression among those North Koreans that made it out and got to South Korea, which obviously would make sense. Application of the nursing process. So the assessment for our patient with somatic disorder is quite complex. It's important to determine whether symptoms are voluntary or involuntary. So here's some different things that we'll talk about quickly. Psychosocial factors, friends, family, spiritual beliefs, work, those kind of things. That's what we want to look at to see what kind of support does this person have in their life psychosocially. Coping skills, what has worked before. Remember, we want to talk to the patient about what they've done in the past and what was successful and what was not. Just because the person ended up back with a somatic disorder doesn't mean that they weren't successful at some point before. That's true with everything, every single thing we come into contact with that a patient can have going on, and it's true for us too. Just because we right now today may not be functioning at our best, at one point we were functioning at a better level. What was working during that time? You know, we are natural human beings, and we abandon things at work at times. Spiritual and religion, is the patient in some kind of spiritual distress? Remember, we want to talk to our patients about that, because spirituality, not religion, but religion, it can be their spirituality, religion, but for us, their spirituality, we're able to treat their spirituality. We're able to help them with their processes and their connection to whatever is bigger than them. Secondary gains, is the patient benefiting from these symptoms? And we're going to talk about that in a little more detail in just a minute. And then cognitive style, misinterpretation of symptoms. Example, patient thinks the headache is a brain tumor. All right, so that's a misinterpretation of symptoms. That I have a headache for the second time this week, I must have a brain tumor. So as a patient, do they have the ability to communicate feelings and emotional needs? Sometimes somatic patients have difficulty communicating emotional needs. Hopefully that makes sense, because now they have physical symptoms because of it. Dependence on medication, pain, sleep, anxiety, good assessment on meds. And then I was going to talk about MAPS when we were in class, but I'm going to end up bringing one in for you guys in a different week to talk about that. We've already addressed it a little bit in PHARM. And then self-assessment. Remember, the illness is real to the patient. Be aware of your own feelings, communication, and body language. There are a couple of you guys, and I know that I've talked to some of you, and I'll talk to you some more about it, that don't realize what your face does when you hear stuff and when you communicate it. So, and again, remember, 90% is nonverbal. So just start, you can even practice that in the mirror. Something that you said to someone, go and say it to yourself exactly the way you said it in front of the mirror, and see what kind of message you're sending when you do that. So different nursing diagnosis that we can give for our patient with somatic disorder: ineffective coping, anxiety, risk for loneliness, powerlessness, hopelessness, social isolation, or risk for some of those. We have to make sure with our outcomes that they are realistic and attainable. It is so important that the patient can actually attain the outcome that we set for them, because we can just sit down and write outcomes all day long. It doesn't really matter what we put on a piece of paper, but can the patient even meet them? Because we're not doing any decent service to them if they can't. And then interventions, the different psychosocial interventions that we'll eventually be going through. And then factitious disorder, okay? These disorders are deliberately and dramatically fabricated symptoms or self-inflicted injury. So patients with this disorder artificially, deliberately, or dramatically fabricate symptoms of self-inflict injury to get emotional needs met and attain the status of patient. The whole goal of creating a fictitious disorder is to assume the sick role. All right, and so we're going to do examples of those. So the first one is self-directed Munchausen's syndrome. This is attention seeking. So you guys have heard probably a lot more about the one following this. So this is just basically making myself sick so I can assume the sick role and that people will want to take care of me. The one that we see, and it's a big problem, is other-directed Munchausen's by proxy. All right, this will see this people, essentially parents, typically it's parents, that will make their kids sick in order to have a relationship with a healthcare provider. So the goal is to get attention and excitement and to perpetrate the relationship with healthcare providers of their dependent or of the dependent. So when we meet together, I have an example to tell you guys about with this. So remind me to tell you guys about Munchausen's by proxy and make sure that I cover that, because you guys will be seeing that. The thing with it is that as nurses, we have to learn how to identify that, because if we don't, we could end up with a child that ends up dead or very ill because we don't protect them from the parent, which is scary that the parent is the one. But this is part of that mental illness. It is a mental illness. It's a disorder by this person. And then malingering, this is a motivated act to deceive based on desire for material gains. So I want to deceive the healthcare, I want to deceive the nurse, I want to deceive the doc so I can get something. So some examples of what I might want to get would be medications, disability, insurance fraud, reduced prison sentence. So an example of malingering would be a guy is getting arrested and being put in the back of a cop car, and all of a sudden he has chest pain and I think I'm having a heart attack, because that's going to get him from not going to prison. He gets to go to the hospital instead. If you've ever seen those shows where they watch people that are on disability and then somebody's watching them to see them like climbing up on ladders and nailing shingles to roofs and all kinds of stuff, you know, they're creating a disorder in order to gain something out of it. Oh, that was the end of that. So anyway, okay, I'll upload that and be working on the next one.